All right, hello everyone. We'll get started in a few moments. We're just going to give a few minutes for everyone to join. All right, why don't we get started? Welcome to Beyond the Predictable to the Possible in Long-Term Care, Rethinking the Future of Aging Services. My name is Emily Trask, and I'll be your moderator. I'm pleased to introduce today's speakers, Irving Stackpole and Michael Wasserman. And I'll just give a brief introduction for both of our speakers. An experienced healthcare professional, Irving Stackpole has held many leadership positions and has managed engagements with hundreds of consulting clients on 5 continents as president of Stackpole and Associates, Inc., a strategy, marketing, and research firm founded in 1991. Irving is widely published and quoted, including in the Financial Times, the New York Times, Forbes, and others. Dr. Michael Wasserman is a geriatrician who has been a tireless advocate for vulnerable older adults during the COVID-19 pandemic. Dr. Wasserman served as a member of the National Academy of Sciences, a framework for equitable allocation of vaccine for the novel coronavirus committee. He is editor-in-chief of Springer's upcoming textbook, Geriatric Medicine, a Person-Centered, Evidence-Based Approach. He previously served as Chief Executive Officer overseeing the largest nursing home chain in California. Prior to that, he was the Executive Director, Care Continuum for California's Medicare Contracted Quality Improvement Organization. Today's webinar is being recorded and will be made available via email to all participants after the webinar for further viewing and sharing. We would love to hear from you during today's presentation, and we'll be answering questions at the end of the session. If you have a question, please feel free to send it through the Ask a Question tab at the bottom of your player. And if your question is for a specific speaker, let me know. If we don't get to your question during today's webinar, we will be sure to follow up afterward. This program has been approved for 1 continuing education credit through NAB NCERS. So without further ado, I will pass it over to Michael.
Okay, welcome, thank you all. And I'm going to talk about a few things, but really focus on what's possible if we engage geriatrics, geriatric medicine. And I'm going to start by sort of setting the stage. Some things that Irving will probably address, but I think are pertinent. Prior to the pandemic, nursing homes actually had 6 months in relationship to the patient-driven payment model, or PDPM. And one of the things about that was if you really wanted to make sure you were getting the most reimbursement, you would focus on how many points the patients coming in had. And I think if we were able to really look at this, we'd see, and there's been some evidence and literature on this already, that we were probably, a lot of facilities were admitting residents with higher clinical complexity. I think it's also worth noting, just prior to the pandemic, in the fourth quarter of 2019, only 1/4 of skilled nursing facilities met the 4.1 staffing recommendations. 31% met registered nurse thresholds, 85% met LPNs, and only 11% met CNA. Excuse the typo there. And so I want to, at some point, I'll speak a little bit about appropriate staffing for acuity, with a caveat that there is an abundance of data that high minority nursing homes with lower staffing levels had worse COVID outcomes. And there is good literature on what appropriate staffing levels based on acuity actually mean. So I'd like to sort of approach this from the caveat of what's really missing in post-acute and long-term care. And I sort of have a circle here that I really like to talk about. And I focus on the geriatrics approach to care, which I'm going to go into a little more depth on, and the structure to allow the geriatrics approach to care to actually live in a nursing facility. And finally, the need for effective leadership to actually implement what I like to call the geriatrization of long-term care. So what's the geriatrics approach to care, and why should this matter? I'm a geriatrician. Back in the mid-90s, there were over 14,000 board certified geriatricians in the United States. As we sit here today, and a number of reports suggested that by 2030, we would need over 30,000 geriatricians for the growing older population. That not only hasn't happened, but as we sit here today, there are fewer than 3,000 full-time practicing board certified geriatricians in the United States. And why is this important? Well, actually, one of my favorite anecdotes for today's healthcare for older adults is going to see the doctor is 3 prescriptions, 2 referrals, and a cloud of dust. And we geriatricians don't practice that way. And I really want to take a little bit of time to help everyone understand when I say geriatrics, what I mean, because there's been a lot of specialties like intensivists and complexivists and sniffists and others that have popped up. But what we really need is a focus on what geriatric medicine and the geriatrics approach to care is. And I'll give you an example I put here on the left of the screen. Function is one of the main tenets. Classic internal medicine focuses on diagnosis, treatment, and cure. The care of older adults focuses on function and quality of life, but many other things. So function is absolutely critical. This is actually me with a photo of one of my former patients who actually lived through the 1919 flu pandemic in the first year and a half of COVID to reach the age of 102. At the age of 88, he was declining physically because his urologist was aggressively treating his prostate cancer. I stopped his medications at the time after the urologist yelled at me, and he never went back on medications and lived to 102 and a half. Function is critical in older adults. Managing chronic disease. It seems an obvious one, but it's highly complex. You cannot do disease management for 12 different diseases. You need to look at the whole person. Person-centered care is not whether people like chocolate or vanilla ice cream, it's whether they like ice cream at all. And person-centered care is absolutely essential to individualization of care in older adults. And psychological and social aspects of care. If we have learned one thing from this pandemic, it's to put a highlight on the issue of social isolation and its impact on older adults. Some other tenets of the geriatrics approach to care are spirituality and the need to listen and communicate. That's something doctors, there have been studies that patients come into a doctor's office and it literally takes 8 seconds before the doctor interrupts them and starts talking. We have to hear what our patients and families say and what their needs are. Wellness is absolutely critical. You know, Medicare was founded with a focus on illness, and we're really trying to switch more to a focus on wellness, which does matter at all ages, but certainly as we get older. And something I like to call realistic optimism and hope. And I think this is an undervalued concept that is really critical. And there's been lots of studies in terms of the mindset of older adults. And the need for sort of realistic optimism and hope is actually an essential element of the geriatrics approach to care. Some of the last tenets include being sensitive to your patient's financial condition. We know there are lots of patients out there that don't take needed medications because they can't afford them. They have to decide between food and medications. Respecting dignity and autonomy, absolutely critical as an ethical construct. Purpose. Also, lots of studies demonstrating the impact of having purpose on both morbidity and mortality, and even in things like demonstrating clinical findings of things like Alzheimer's disease. And finally, I like to say that those of us in the field of geriatrics invented the concept of the interdisciplinary team in healthcare. This has been a basic tenet of geriatrics for many, many years. And I think separating the concept of team from the practice of the geriatrics approach does a disservice to the geriatrics approach to care. You need both. And so why am I such a believer in the geriatrics approach to care? Well, number one, I could say that over the past nearly 40 years, I have seen it work in many different settings with lots of experience in large practices, reviewing a lot of the literature. And there are examples. The PACE program is an absolute example and gold standard for the effectiveness of the geriatrics approach to care. And typically PACE programs are staffed by geriatricians. The GRACE program, Geriatric Resources for Assessment and Care of Elders, has plenty of literature to document the value of a geriatrician-led team. And keep in mind, when I say geriatrician-led, I don't mean that the geriatrician just is authoritative and autocratic. The geriatrician acts as a member of the team, but leads the team in the care of older adults in primary care settings. And finally, I love to bring up the acute care of elderly units, which is a hospital unit focused on older adults using the basic tenets of the geriatrics approach that has a lot of literature behind it and showing benefit in quality of care, cost, length of stay, you name it. And the number of these units has only gone down over the years. And a lot of this is actually due to financial reasons. You know, when you do a really good job of taking care of older adults, you reduce hospitalizations. And one of the problems in our healthcare industrial complex is when you reduce hospitalizations, when you reduce procedures, when you reduce medication use, you're reducing a significant amount of revenue into the system. So it's a problem I'll leave to Irving to talk a little bit more about in terms of how the intersection of economics impacts care. But I will say that there's plenty of experience and literature that demonstrate that the geriatrics approach to care works. So with this, as we look at the background of where we are with nursing homes today, especially in light of the COVID pandemic. In 2014, the Office of Inspector General made a number of recommendations in a report of adverse events in skilled nursing facilities. And I'm not going to go into detail over all the adverse events they found. We all know that there are a lot of challenges in long-term care and in nursing home care. The focus of the 2014 OIG recommendations were to raise awareness of adverse events and to develop QAPI programs. And I can answer questions about QAPI later on. QAPI is basically a construct that came out of the 80s and 90s in quality improvement and CQI and TQM and you name it. And it was sort of administratively decided that nursing homes would have these quality assurance performance improvement programs that would focus on adverse events with staff education on the range of potential harm, developing strategies for detecting and measuring, and then developing best practices for improving staff recognition and reporting. And honestly, actually having run the nursing home arm of a quality improvement organization, I can tell you that I am a huge believer in the concept of QAPI, but like many concepts, unless it is executed effectively, it doesn't work. And so I really like to link up QAPI to the geriatrics approach to care. I mentioned the need for good leadership at the facility level. You really need a team that recognizes the need for all the staff in the facility to understand the geriatrics approach to care and engage with all the staff in terms of quality improvement. Which actually brings me back to one of my favorite topics for over a decade. Back in 1974, the first report about nursing homes came out by the Senate Committee on Aging. And it was entitled, Nursing Home Care in the United States, Failure in Public Policy. Next year will be the 50th anniversary of this report. And I want to highlight the recommendations of this report because I think we have a fundamental problem in all of healthcare, but it really shows up in nursing homes and in long-term care in terms of a lack of understanding of the geriatrics approach to care. And I go back to what I said earlier. If you have physicians who are prescribing unnecessary medications or admitting people to the hospital unnecessarily or doing unnecessary procedures or any of those things, you're going to have an impact on the quality of care. And I will stand by the fact that those of us in the field of geriatrics, and that includes physicians, nurse practitioners, pharmacists, social workers, any number of disciplines that have some degree of specialization in geriatrics. So back in 1974, the Senate Committee on Aging recommended that US schools of medicine put greater emphasis on geriatrics. By the way, this was with the foreshadowing that 50 years from then, the baby boomer population would have been aging in and the number of older adults would be increasing, which that number is now 17% of the population. It was recommended that we establish departments of geriatrics in schools of medicine, that we should provide training for PAs and nurse practitioners to work in nursing homes. By the way, geriatric nurse practitioner training programs essentially don't exist any longer. They did for a while and they got rid of them. A program should be enacted providing funds to schools of nursing to establish training programs for nursing home personnel. Schools of nursing, social work, public health should provide education in the specialty of gerontology and geriatrics. I really want to sort of hone in and focus on the fact that it's almost 50 years later, and not only haven't we done this, we've gone backwards. And if we don't understand how to care for the folks we care for in nursing homes, I would opine that all the other incentives and programs and models are not going to work effectively. There's a lot of discussion around care coordination and case management, and there's been actually plenty of studies that show those things don't work unless you have what I like to call the secret sauce. And if you look at successful programs, you're going to find geriatricians, you're going to find geriatric nurse practitioners. Just look at programs like what was Evercare, which is now Optum. You're going to find geriatric social workers and geriatric pharmacists. And until we do that, I really have concerns about how much progress we'll be able to make regardless of the other mechanisms. And I sort of want to close with going back to the nursing issue I brought up at the beginning of this, because the vast majority of care in nursing homes is provided by CNAs. And the clinical licensed eyes and ears in nursing homes are the RNs. And the doctors come and go, the pharmacists, don't even get me started on how much we give to pharmacists time-wise in nursing homes. But the nursing staff, the frontline staff, even the housekeepers. And I've done training in facilities where I bring the housekeepers in to help them understand things about the frail older adults that we care for, because they're also eyes and ears that can help us, which sort of brings me back again to those three entities: the need for the geriatrics approach to care, the structure to allow it to exist in nursing homes, and then really the importance of the entire leadership team, the administrator, the DON, the medical director, the director of staff development, and today, even most importantly, the infection preventionist. The entire team needs to embrace this. And until we start training folks in this, it's really going to fall on all of us and the facilities themselves to either provide additional training or encourage additional training in order to do this, or one of my favorite topics, to engage their medical director fully from an educational perspective. So with that, I am going to return the slides back to Irving or Emily.
One of us. Thank you, Dr. Wasserman. Show my screen. Show your screen. I guess we get to all see my screen. Can you all see my screen? Emily or Mike, can you see this?
Yes.
Okay, great. So thank you, Dr. Wasserman. Again, very provocative, right to the heart of it. How can we care for people in long-term situations if we don't know what we're doing? I mean, if the training isn't there, what hope can there be for being able to serve those in need of care? And I'd like to extend the conversation in long-term care past the congregate units, past the nursing centers, past the assisted living residences, past even the independent housing, toward the whole concept of long-term care, the whole concept of caring for persons of age with chronic illness who need support in this home and community-based services, home health care, and more. And the current question that I'd like to raise, we've all looked at, Michael just went through some unbelievably sobering information about the number of qualified geriatricians. It's going backwards. The number of qualified geriatric pharmacists, it's not growing. The number of qualified geriatrically trained, properly trained nursing and certified nursing assistants, if you look at it in terms of available supply and available demand, it's going backwards. And the question is, have we reached a point where the combination of problems is sufficiently painful and unacceptable to prompt real substantial change? And by this, I mean, are we at a critical juncture? Very important definition here is that a critical juncture is a point at which real substantial change occurs. And I'd like to use the insight that we don't want scapegoats. We don't need ideologies about being advocates for particular staffing ratios or any other things, but we need specific policies. And unfortunately, I'm hard pressed to see real policy changes being manifest, being shown and demonstrated. And there's two kinds of change. Incremental change, what we have now, which is sort of like putting lipstick on a pig. And believe me, I love pigs. So this is not in any way a derogatory metaphor, but really putting the lipstick on doesn't really change what it is. Or we can have fundamental and disruptive change, which is all about changing the way we look at, think about the underlying issue. Are we at a sufficiently painful point in time where we will experience this fundamental change? The political, economic, social, and ethical foundations are that the United States is a very generous and caring culture. We don't step over people who have been hurt, and yet we tend to sequester people in long-term care. We tend to look past their needs, and certainly the ageism that was manifest during the pandemic and the deaths that occurred there in long-term care centers lends credence to that we're a generous and caring culture. We don't let people die in gutters. We don't step over them on the way to get a cup of coffee. Also, that we expect help when we really need it. There's a social contract that exists between the public at large and the government. We just expect that help will be there when we really need it. This goes to the heart of why there hasn't been more of an outrage about the lack of available long-term care support and services. People, survey after survey, have shown that we as a population expect that long-term care needs will be provided, will be available when we need them. And that's part of the social contract. And the question is, will the help be there when we need it? Almost regardless of who's going to pay for it, will the help be there when it's needed? So will the nursing center be there? Will the home health aide be there? Will the residential support be there if and when these things are needed? Now, I said I wanted to talk about more than nursing homes, and I will, but Dr. Wasserman set this issue up. In fact, what we've seen is a decline in the available skilled nursing centers. We've seen a decline in nursing homes in the United States. And in the 8 months in 2022, we've seen more closures in nursing centers than in any other similar period previously. And I've talked about this before. I call it a fatal contraction. There's been a contraction in the supply in skilled nursing centers, and it's continued, and it will be and is continuing to be very severe. Too many are closing, too many of the wrong kinds are closing, and at the wrong time. The direct care workforce similarly is contracting. I heard an estimate recently that we've lost over 400,000 individuals in the direct care workforce in long-term care. And here we see some data from the Labor Department that shows that indeed that is the scale of the loss of workforce. So we're losing beds, we're losing available capacity in residential care, we're losing workforce in skilled and in direct care workforce and long-term care, and we're about to incur a even bigger hit in this because the demand will increase shortly for these services because of demographics. So there's a secret source of supply in this situation, and I call this this is the unpaid care economy. So we can see that unpaid caregiving in the United States has an estimated value of about $3.5 trillion, which is more than the paid caregiving economy, and certainly more than what these authors refer to as the gray economy. What I'm pointing out here is that many of us here on this call have stepped up in one way or another to care for an aging or a chronically ill person in our circle of family or friends. And this service, this unpaid care, is a drag on the economy. It's a challenge to us personally. It prevents us from doing the things that we want or are being paid to do or should be being paid to do. And it's certainly a problem, and it's driving the economy toward a critical juncture. So the questions, the agenda, I think, that needs to be tackled, including the issues that Mike brought up around available supply of geriatricians, is how does CMS regulate this sector? How does CMS regulate long-term care? Highly fragmented, highly politicized. How is capital created that is then invested into the structure? We've lamented before about the poor infrastructure in long-term care. I like to think of it as the sector that technology left behind. How do intermediaries pay? Mike mentioned what had been Evercare became Optum. It's an innovation model in long-term care, and they've made it work. United/Optum have made it work. In fact, they've made it very profitable. How are these and other intermediaries inserted in aligned with the agenda, the economic, social, and ethical agenda? How the public sees long-term care. Most people don't understand how long-term care is provided either in the community or in residential centers. We need to substantially increase the technology in the sector. The only way to improve the productivity of individuals in the paid workforce, in the direct care workforce, and that's an essential part of what has to happen going forward. The only way to do that is by increasing the technology that's deployed. And it's not just robots, it's not just what you think of as a robot, it's not a 3CPO walking up to bedside and taking vitals. It's ambient monitoring of individuals and consumers and actors in long-term care, in the community, in residential care settings. The technologies exist. They simply haven't been deployed because currently there's no incentives to do that. And obviously, many of you are familiar with the issue of tort reform, the issue of legal liability for malpractice. These are issues that are too often bandied about and scapegoated. There's no rational political policy approach to reforming and redoing the legal body that the case law body that covers long-term care. And then finally, and it seems finally, the issue is how do we make the sector, long-term care sector, more sustainable? There are significant steps that could be taken to address these and other factors. So we look at the economics and politics, the USA, the United States spending by category. The United States spends 46% more than other OECD countries on long-term, spends 46%, less than half of other OECD countries on long-term care, and 243% more on inpatient and outpatient care. Does that make any sense? Well, according to the death rates and infection rates in long-term care centers, in long-term care, overall, during the pandemic, I would say not. But these numbers don't make any sense. Economics and politics, the United States healthcare system for the citizens in the United States is a bad deal. Here we can see that the healthcare spending versus life expectancy, and this is from 2015, the numbers have gotten substantially worse. There are all these countries here that do way better than the United States in terms of life expectancy. And this doesn't take into account issues of morbidity like obesity, blood pressure, coronary artery disease, et cetera, where the disease burden is significantly higher. So these are the economic and political facts, the backdrop against which we look at how to care for persons who are chronically ill or persons who are older and are referred into the long-term care system in the community or in congregate centers, skilled nursing, intermediate care nursing, LTACs, whatever the venue is. This is the background and the context, and it's really not a happy position. The question is, of course, is this enough? Is this a critical juncture for long-term care, or will we get more incremental change and more lipstick rather than real substantive and fundamental change? This is the question. There's no solid answer, but this is the question that I'd like this audience and others to weigh in on and to start a discussion with regards to these factors. So I'm going to see what sorts of questions we have. Got a good audience. Let's see what people are thinking.
All right, great, thank you. Thanks to both of you. We have a few questions here. This one is specifically for Michael. Could Dr. Wasserman share any of the research that he mentioned about the lack of efficacy of case management without that secret sauce of geriatric approach to care?
Yeah, actually, the literature goes back to the 1970s with something called the channeling study that looked at case management to try to keep people out of the hospital, keep people out of nursing homes. And the study was a negative study. I'll fast forward up to the early 2000s when CMS did a care coordination demonstration project. And CMS has had multiple demonstration projects that ultimately show a lack of efficacy. And in many of these projects, they then put them into policy, which doesn't make a lot of sense. So as an example, the care coordination demo did not show benefit, but when you dug deep into it, you found pockets that did. And those pockets typically had geriatricians and geriatric teams and such. So again, study after study of care coordination, one of my favorite metaphors on that is that if we had a group of case managers and care coordinators telling people that the world is flat, that wouldn't make the world flat. And so we're ignoring the fundamental importance of understanding how we care for older adults, as Irving said, across the entire continuum. So long as we have doctors overprescribing medications, ordering more tests, doing unnecessary treatments, how are we going to stop that? I mean, I think that's the problem. And, you know, I'll give one provocative statement to everyone, and it really goes to what the last slide that Irving showed here with how much we spend. It is my belief, and honestly, many of my colleagues have, actually almost all of my colleagues have validated this for decades. If we were to truly geriatricize the healthcare continuum and train everyone in providing good geriatrics care, Medicare expenditures would go down 30%. Okay, the problem is we have an entire healthcare industrial infrastructure that is dependent on that revenue. So if all of a sudden we had doctors who prescribed fewer drugs, who ordered fewer tests, who didn't put their patients in hospitals as often, $300 billion would disappear, and we would have just imagine what would happen to our healthcare economy. So we have some interesting socioeconomic challenges if we really want to geriatricize the entire healthcare continuum. By the way, the families and the patients would all be happy because they'd be getting better care.
Right. But those are fascinating observation, Mike. And I'd like to jump on this, on what you said, taking your last point first and going sort of in reverse order. Qualitative analysis of the satisfaction of families with long-term care, systematic, it doesn't exist in the United States. There are surveys, there are standards, but they're just not deployed, which makes no sense. We're measuring all this quantitative information through CMS, and yet we're not evaluating the impact that our long-term care provision has upon the perceived quality of life, or just the satisfaction of, importantly, the consumers themselves or the family, should the consumer not be able to report his or her happiness. And going in reverse order, it's been known for decades that the fragmentation of the United States healthcare system contributes more, almost twice as much as the next closest reason why our healthcare system is twice as costly as any other developed economy. It's this very fragmentation to which you referred that creates this additional cost burden. Evidence of this fragmentation is the fact that in the United States healthcare system, we spend $800 billion with a B on administrators. That's the personnel needed just to keep all the ducks in a row. And were we to, going back to QAPI, going back to my days in statistical process analysis, if we were to rationalize, drive a tube through the silos of care, pharmacy, long-term care, medical equipment, skilled nursing, hospice, et cetera, it goes on and on. If we were to rationalize across that, there would be significant unnecessary expenditure taken out of the system. Now, I don't want to threaten hospitals or doctors or any other profit center in the United States healthcare system, because United States healthcare system is a significant part of everybody's pension. And we don't want to destroy the stocks and the bonds in those categories. But there's significant inefficiency bordering on disastrous waste in the system that can be extracted without creating a race to the bottom, which I believe that value-based healthcare has terrific benefits, a terrific offering, but significant part of its application is a race to the bottom. So I think there's all these opportunities. And my question, and I'd like to get Dr. Wasserman's take on this, my question is, are we at the point, Dr. Wasserman, where we are at a critical juncture, where the system is so broken, so no longer fit for purpose, that we're going to see significant, substantial, really disruptive change?
Honestly, I think there's no question. And I think in its own way, COVID unmasked this. For all the pats on the back that government entities give themselves for COVID response, our response puts us right about where your slide on spending and life expectancy is in terms of how we've done. I mean, look at Japan and how many older adults died from the pandemic. Look at Israel and how many folks died. Look at New Zealand, which isn't on here but is similar in there. We absolutely, and I'll give you one example. We can go into a Amazon or a supermarket and buy our groceries and leave without ever going through a checkout stand or doing anything. Why can't we use technology to capture everything that a nurse and a CNA does in a nursing home so they don't have to spend time inaccurately, by the way, and there's plenty of literature about the inaccuracies of all the documentation in nursing homes, inaccurately documenting what they did. This is all technologically doable, and there's an irony there. If you take away that administrative inaccurate time that we spend, you're giving more time for those staff to spend with residents, and it would be a significant change. So I think, and I point out, many of my colleagues worry about my field of geriatrics. I think the field of geriatrics is nearly extinct as we sit here. And I really worry that when there are no geriatricians left, what are we going to do to assure that doctors, nurses, and others actually know how to care for older adults? I really worry about that.
And this is as I and others have pointed out, this juncture where we are, this crossroads, if it's not a critical juncture, this point in time is really, we've got it easy, relatively speaking, because the earliest edge of the baby boom, which is me, aren't in our high consumption years yet, and won't be for another 3 to 8 years, depending on how you count it, and depending on how you adjust for our lifestyles and behaviors. So we really need in my opinion, we need a forward-looking policy that cuts away the barriers that were put in place by fundamentally the government, which is the largest single payer, the barriers that were put in place in order to protect expenditures from fraud. So there's a lot of talk about fraud, but when you look at the percentage of it in the long-term care arena, it's minuscule, it's very small. And that distracts us because there are moralistic and ideological actors who are trying to scapegoat. And that distracts the energy from creating rational policies about pharmacy, harmonization of pharmacy across the care continuum. An individual, my mother, if she were healthy and needed to have a hip surgery, and then had to go to a nursing center for rehabilitation and then had to go home again, she could be exposed to 4 different formularies, none of which are harmonized. And that to me is irrational when there's very good data to show that 40 to 70% of inappropriate hospital readmissions are entirely due to pharmacy, entirely due to the poor utilization, polypharmacy, non-compliance, non-adherence, whatever the term is these days. But these factors are so critical. We need to wipe that away. We need a new, fresh approach. yeah, I shouldn't get too carried away. The NASEM report, which many of the folks in the audience will know about, unfortunately refragmented the issues by assigning a group of people to look at finances and a group of people to look at something else in the NASEM report. And that's an example. You have to break up the problem in order to piecemeal it, and the solution will be similarly piecemeal. And my major concern is that we'll have another event, we'll have another significant public health event, and that will result in truly profoundly unnecessary and extensive morbidity and mortality. So let's see what other questions there are, Emily.
Great. We have a number of questions and comments, so hopefully we can get to most of them. And this is for you, Irving. What is the relationship of the geriatric workforce to our immigration policy? Do you have any suggestions to remedy this?
Yeah, thank you. It's a very, very good question. The first and simplest is to reinstate the H-1A visa. This was a very successful visa program, which was lobbied out of existence by certain self-serving interest groups. The good-meaning people can disagree on policy, but we need the H-1A program. We need it back, and we need it back fast. Certain forward-thinking providers in the long-term care space have already invested millions in bringing workers in from outside of qualified workers in from outside of the United States. There are sources for these qualified workers, and there should be lubricated channels that allow them to show up and work for the home health care agencies and the home and community-based service agencies and the long-term care providers who need them.
Right. Dr. Wasserman, my medical students are currently graduating with $300,000 to $400,000 of student debt. If they were interested in being geriatricians, they likely could not afford to. Do you have any recommendations?
Well, actually, I will point out, geriatricians, study after study, have been shown to be the most satisfied and gratified of all physicians. So in a time when burnout is high and people are leaving the field, I think that does count for something. Number two, I think if we recognize the critical juncture we're at, and the marketplace does realize we're going to have to focus on geriatrics, I think there are opportunities for reimbursement. I know these are policy issues, but there's no question. I think there's a three-sided stool to increasing the number of geriatricians. One actually is just requiring the training. The government takes $10 billion over $10 billion out of the Medicare Trust Fund to subsidize physician training every year, and they use that money to train doctors how not to take care of Medicare beneficiaries, which is a horrible thing. So, but number two, improving reimbursement. Geriatricians are the lowest paid specialty in healthcare. If we made geriatrics one of the higher paid specialties, we could start moving folks in that direction as well. So I think, and then making sure in medical schools that students get positive experiences, not just in hospitals, but in outpatient settings with older adults, to see the positive nature and develop positive role models. Those are the three things that I would do.
May I add something to that, Dr. Wasserman, that there could be a very simple policy solution that would immediately open the spigot, and that would be a debt forgiveness program, like a national health service program for geriatric doctors and geriatric nurses to go into nursing centers, to go into rural nursing homes, to go into rural home health agencies, and to pay down or credit down some of that student debt.
I agree. Sorry I missed that one. You're absolutely right. That is immediate.
Okay, thanks. In terms of going backwards, decrease in ACE, decrease in geriatricians, et cetera, Is any of this due to ageism in our culture, and is there a movement surfacing to change that? And who at the federal level can become a champion for elders and LTC? Other countries are doing much better. What is stopping us from the US in doing the same?
So yes, absolutely. I have one policy recommendation. You will not find experts in geriatrics in policy-making positions in the federal government. Over the last 4 decades, the number of folks with expertise in geriatrics and gerontology who have been appointed to policy-making positions, I can count on less than on one hand. And most of the folks in those positions are lawyers and administrators, or basically most of them are lawyers actually. So the problem is we're not putting the right people in that place to combat the underlying ageism that already exists, not only in our society, but in the legislature.
Also, we have a geriatric president. And we see how the media and how the public positions him and adjusts his credit score, adjusts it based on his age, not on his shrewdness, not on his wisdom, not on how many times he's been, for example, to Ukraine. And this is not a political advocacy, but merely a cultural observation that we have this president who's just turned 80. He's breaking all the molds, and we can't recognize, support, praise that.
100%.
And this is sort of along the same lines about leadership. And the person says, I was heartened to see that Dr. Wasserman suggested that leadership was an important requirement for sustaining quality at the bedside. Can you explain how CMS, IOM, and NASM studies fail to understand this basic need?
So honestly, there's literature going back over a decade demonstrating consensus style or servant style leadership is associated with lower turnover, greater quality measures. We have the data on this. We also have the experience on this. Honestly, I believe that the survey process should actually move towards looking at leadership skills and leadership types. And honestly, the survey process needs to change. It needs to become more collaborative. Again, that may require legislation because it was built to be punitive. I don't believe it works that way. But we must focus on leadership. I'll throw out one last thing. The administrator of a nursing home is the CEO of one of the most complex small businesses in the history of mankind. What skill set do we require of them from a leadership and management perspective? And not to put down a lot of administrators who have the right heart and are doing their best, but we don't arm them with the right skill set to do what they do, and the pressures they face from the financiers of their facilities just is why my number one focus these days is on transparency, so we can get at all the waste of the money that goes into long-term care.
Great. In your expert opinion, is the federal plan to deinstitutionalize senior chronic care and close all nursing homes like it was for the developmentally disabled years ago?
Oh my. So this is, so let me just say that the deinstitutionalization of persons with behavioral and mental disorder will go down in history in the United States as one of the cruelest and most expensive public health blunders that we've ever experienced. The information, the data about this is overwhelmingly negative. That is to say, persons with behavioral and mental health disorders are almost 100% more likely to be arrested, imprisoned, involved in serious crime. And this is all a direct result of the deinstitutionalization of these individuals. What's happening de facto in long-term care is that the supply is shrinking. The demand, there's a threshold demand for these services, which can no longer be fulfilled with the available supply. And the supply, whether it's workforce or inventory of congregate care rooms, is further shrinking. So we're de facto deinstitutionalizing the sick, elderly, and disabled in the United States. This is a de facto occurrence, which makes me wonder what it's going to take before we do something that's disruptive and meaningful in the sector.
All right, so we have a number of other comments and questions, but we're at time now, so we can try to answer some of those questions offline.
Yes.
All right, do you have anything in closing that either of you would like to say?
I want to say thank you to Dr. Wasserman.
And thank you to Irving, thank you to Emily, and thank you for everyone who's participated.
Great. Thank you for everyone for attending our webinar. We hope it was informative, and when you receive the survey, please let us know how we did so that we can plan for future programming. Have a great day and stay well.